When someone struggles with persistent intrusive thoughts or can't seem to shift their attention away from certain tasks, the underlying cause isn't always obvious. Both ADHD and OCD can produce remarkably similar experiences from the outside: minds that appear stuck, attention that seems hijacked, behaviors that look repetitive or scattered. The distinction lies not in what we observe, but in the neural mechanisms driving these experiences. Misdiagnosis between these conditions can lead to years of ineffective treatment approaches, because interventions that help one condition may actually exacerbate symptoms of the other. Clinicians regularly encounter patients who have been diagnosed with both conditions at different points, or who have received conflicting opinions from different practitioners. The college student who compulsively checks her email might receive an ADHD diagnosis based on her inability to focus on studies. The executive who repeatedly reorganizes his workspace might be labeled with OCD due to the repetitive nature of his behavior. In many cases, these initial assessments miss the mark. The diagnostic confusion occurs because both conditions disrupt executive functioning, the brain's capacity for planning, sustained attention, and impulse control. Both can produce apparent distractibility, difficulty transitioning between tasks, and cognitive inflexibility. When we focus primarily on observable behaviors rather than underlying mechanisms, we risk treating the symptom rather than the system that generates it. This distinction matters because treatment approaches differ fundamentally. Stimulant medications that improve ADHD symptoms can worsen OCD in some individuals. Cognitive behavioral therapy for OCD emphasizes accepting uncertainty and reducing control behaviors, while ADHD interventions typically emphasize structure and predictability. When the wrong framework guides treatment, interventions may not only fail, but can sometimes intensify the very problems they're meant to address. Understanding these conditions requires examining what's actually happening in the brain during moments of apparent inattention or repetitive behavior. Consider how your brain manages attention under normal circumstances. The prefrontal cortex acts as a filtering system, determining which information deserves focus and which should be ignored. This system isn't perfect, but it generally maintains a workable balance between attending to relevant information and filtering out distractions. In ADHD, this filtering system operates inefficiently. Russell Barkley's research at Virginia Commonwealth University has mapped how certain prefrontal cortex regions show altered activity and connectivity patterns in ADHD brains. The result isn't a choice to attend to multiple things simultaneously. It's a fundamental difficulty in controlling what captures and holds attention. People with ADHD can experience intense focus, sometimes called hyperfocus, but they struggle to direct this capacity toward chosen priorities. OCD involves a different pattern entirely. Jeffrey Schwartz's pioneering brain imaging studies at UCLA in the 1980s and 1990s revealed increased activity in the orbitofrontal cortex, anterior cingulate cortex, and caudate nucleus. These regions handle error detection, emotional processing, and habit formation. In OCD, these areas generate persistent signals that something requires attention or correction, even when no actual problem exists. Compulsive behaviors temporarily reduce this neural alarm, which reinforces their repetition. The fundamental difference is this: ADHD reflects underactivity in cognitive control regions, while OCD reflects overactivity in error monitoring systems. These opposite patterns of brain function explain why the conditions can appear similar behaviorally while feeling entirely different subjectively. When someone with ADHD gets stuck on a task, their attention regulation system fails to maintain priorities. They might begin organizing their desk, notice a book, start reading, remember a phone call they need to make, check their phone, see a notification, and find themselves 3 hours later watching videos about medieval architecture. The sticking isn't intentional. It's their filtering system failing to maintain focus on what matters most. When someone with OCD gets stuck, their brain signals that something catastrophic will happen if they don't complete the task correctly. They're not distracted by the task, they're trapped by it. The anxiety compels repetition, checking, or perfecting until the discomfort temporarily subsides. The issue isn't an inability to shift attention, but rather that shifting attention feels genuinely dangerous. Edna Foa's research at the University of Pennsylvania demonstrates that this difference appears in treatment response. People with OCD benefit from exercises that increase tolerance for uncertainty and imperfection, deliberately making mistakes or leaving things incomplete. This approach typically increases stress in people with ADHD, whose primary challenge is inconsistency rather than perfectionism. The attention difficulties in OCD stem from what researchers call cognitive load, when the brain constantly runs background processes, monitoring for threats, planning compulsions, managing intrusive thoughts. Less capacity remains for other cognitive tasks. The attention problems feel internal rather than external, not, I can't focus because everything distracts me, but I can't focus because my mind won't stop. The diagnostic picture becomes more complex when both conditions occur together. Research from Gail Bernstein at the University of Minnesota indicates that up to 30% of people with OCD also meet criteria for ADHD, and studies consistently show elevated OCD rates among people with ADHD compared to the general population. These conditions can interact in ways that amplify both. ADHD impulsivity can trigger OCD obsessions. If you're prone to acting without deliberation, you're more likely to experience those "did I lock the door" moments that can develop into compulsive checking patterns. The ADHD tendency to miss details can create genuine uncertainty that an OCD-prone brain interprets as evidence of danger. Conversely, OCD compulsions can worsen ADHD symptoms. Mental energy devoted to rituals and obsessions reduces the cognitive resources available for attention regulation, making an already challenging task more difficult. Both conditions involve executive dysfunction, but in different domains. ADHD primarily affects working memory, cognitive flexibility, and inhibitory control. OCD primarily affects set shifting, the ability to transition between different tasks or mental frameworks. When both are present, multiple types of executive impairment operate simultaneously. Children present particular diagnostic challenges because pediatric OCD often manifests differently than adult presentations. Young people with OCD might appear unable to finish homework, have difficulty transitioning between activities, or seem inattentive because they're internally focused on obsessions. These presentations can easily be mistaken for ADHD. The research landscape includes important limitations. Many studies establishing comorbidity rates use relatively small samples, and diagnostic criteria have evolved significantly over recent decades. The DSM-5 changes allowing adult ADHD diagnosis without clear childhood onset have complicated our understanding of how these conditions interact across development. Gender patterns add another layer of complexity. ADHD has historically been underdiagnosed in girls and women, partly because it often presents as inattentiveness rather than hyperactivity. OCD shows different symptom patterns by gender. Women more commonly experience contamination and cleaning obsessions, while men more commonly have symmetry and ordering compulsions. Treatment complications arise because interventions for one condition can affect the other. Stimulant medications may worsen OCD symptoms in some people, possibly through dopamine's role in both reward processing and habit formation. This means integrated treatment approaches must consider how addressing one condition might influence the other. Understanding these mechanisms changes how you might evaluate attention and focus difficulties. The internal experience matters more than external behavior. If you struggle with attention or getting stuck on tasks, consider what drives these experiences. Does your brain feel pulled in multiple directions or stuck in one direction? Are you distracted by everything or consumed by something specific? The quality of stuckness provides important information. ADHD stuckness often feels passive, you find yourself somewhere without clear awareness of how you arrived there. OCD stuckness feels active. You understand exactly why you're stuck and feel compelled to remain until something resolves. Consider patterns across time and contexts. ADHD symptoms typically remain consistent across different environments. Distractibility appears at work and home, in high-stress and low-stress situations. OCD symptoms often have specific triggers and can vary dramatically based on anxiety levels and circumstances. Notice what interventions help. Do you benefit from increased structure and external organization, or does structure sometimes increase anxiety? Do you improve with strategies that help you slow down and become more deliberate, or strategies that help you process information more efficiently? These responses can indicate which underlying mechanisms are involved. If both conditions seem relevant, recognize that they may require different treatment approaches. Cognitive behavioral therapy can be adapted to address both ADHD executive functioning challenges and OCD anxiety management. Medication approaches might involve non-stimulant ADHD medications or carefully coordinated timing of different treatments. For parents, this understanding suggests caution about rapid diagnostic conclusions. A child who appears inattentive might be internally managing obsessions. A child who seems hyperactive might be engaging in subtle compulsions. Understanding the driving mechanisms matters more than categorizing the visible behavior. Adults who have struggled with focus and productivity might consider whether they've been addressing the wrong underlying system. If ADHD focused productivity strategies consistently fail, the brain might be anxious rather than distractible. If mindfulness approaches for apparent anxiety make things worse, the brain might need help with information processing efficiency rather than slowing down. The crucial insight is that particular patterns of stuckness or distractibility reflect specific neural systems that need support. Effective intervention requires understanding the actual mechanisms involved, not just their external manifestations. ADHD and OCD represent different types of cognitive control difficulties that can produce similar observable outcomes through entirely different mechanisms. ADHD involves inefficient filtering systems that struggle to prioritize relevant information. OCD involves hyperactive error detection systems that signal problems where none exist. Both can create apparent distractibility or repetitive behaviors, but the underlying causes point toward different solutions. Understanding these distinctions matters because effective treatment depends on addressing the actual neural systems involved rather than just managing surface symptoms. When we recognize that attention difficulties reflect specific information processing patterns rather than general cognitive failures, both assessment and intervention become more precise and more likely to succeed.